Hi, welcome everybody to the Digital Transformation and Public Health panel. Today we're going to be talking about advances in health IT that are allowing for better management of public health. You're going to hear from industry experts in both government and academia as they discuss how new technologies will assist health networks in both managing the demands of COVID-19 and better anticipating the challenges of tomorrow. Please welcome to the panel, Jonathan Alboum, Federal CTO and Principal Digital Strategist from ServiceNow, Dr. Andrew Gettinger, Chief Clinical Officer, there's a private joke in that one, Jonathan Weiner, Founding Director and Center for Public Health Information Technology from the Bloomberg School of Public Health, Johns Hopkins University. Myself, Andrew Underhill, will be moderating this conversation. I'm from GovernmentCIO. So, without further ado, let's get to the first question. So first to Dr. Gettinger and then to Dr. Weiner. What have been some of the major achievements in health IT over the last 12 months, given the state of the pandemic?
Well, this has been an excellent program since it started, and a number of the prior speakers have actually called out some of the incredible changes. Healthcare is frequently called a system that doesn't move fast, doesn't change easily, is sort of dug in. Well, in fact, telehealth, telecare, transitioned almost overnight. Now, that wouldn't have been the case absent some of my federal sister agencies making it possible. So both the Office of Civil Rights in the privacy space, CMS in the requirements for billing, they're loosening up those regulations actually made that happen. The other, in my agency, the Office of the National Coordinator, we very, very quickly, if we're going to learn anything about COVID, if we're going to learn anything about any new problem, syndromic issue, we're going to need to be able to record it in the record and then track what happens with patients. So very quickly, we pivoted, made sure that the EHR developers had implementation guides to include both the diagnostic testing, the diagnosis of COVID and its variants. And we're looking forward to seeing the documentation of the vaccines and how long they're effective and what their complications are. The last thing I'd say, and again, we heard about this before, is implementation of systems across the country, both within the government and outside the government, went from a complicated hands-on affair to being able to be implemented remotely and have the education done remotely. I'll stop there and let some of my colleagues speak.
Andrew, I'm pleased to be here. Thanks for inviting me, and I'm also very pleased to talk to my colleagues around the country. Coming second, the first thing I can do is comment on Andy, Dr. Gettinger. I fully agree on the telehealth. We've gone from less than 1% to a recent study I'm completing shows nationally about 25 to 30% overnight, and it's not going back. But this is a panel on public health, more so than medical care, and I think that this pandemic, although everybody has really stepped up to the plate in every way they can, it shows the structural challenges that we've had in the public health and population health domain. I use the word population health, by the way, to talk about the integration between public health and medical care. And I think it's shown, as much as people have tried, and both government and private sector has certainly ramped up surveillance. I would say our public health surveillance now is about 2 or 3 times better than it was just a year ago with the hard work that both private and public have done, but it's probably about 1/10 of what needs to be. So you asked the half full question rather than a half empty question. So I know we'll talk more about the challenges. But it also has shown, all the great work that ONC and others have done on interoperability have been very important. But on the other hand, it also shows the lack of interoperability we have, particularly from a medical care public health integration. We'll come back to that perhaps later in our half an hour.
Thank you. So within 2020, obviously, we've seen remarkable impacts that technology has played in various efforts regarding coronavirus, treatments and tests, clinical trials, vaccine development, etc. What are the major challenges that you have seen in your respective roles, and how did you overcome those challenges last year? First to Dr. Weiner.
You'd like me to go first? Sure. The challenges are some of the ones that we've already mentioned. I mean, I think technology and its response has been phenomenal over the last year. Case in point, the rapid move toward the vaccine and the use of genomic. But again, I believe that the advances that we've had in medical care, pharmaco, have also shown the challenges we've had in public health. So, I'll let the other Jonathan or Andy talk about specific technological successes within the public health domain. There have been some, but I believe just putting things in place and blocking and tackling and hard work on many parties has been more important than the technology in the public health domain in most cases.
I think that makes sense. I think one of the reasons why you're able to say that and think about it that way is, at least in the federal government, we had made hefty investments in IT modernization and digital transformation technologies in the years leading up to this. So when it came time to pivot to a digital approach, whether it's telehealth or serving other federal customers through digital means, we were able to do it. We already had some telework technologies, but I don't know that there was an agency out there, at least at the federal level, that was about full-time telework. So my colleagues in the federal government, and I worked in the federal government for many, many years, we want to get the job done in the best way possible. And this time it's doing it, remotely. And in a lot of cases, there were maybe some bumps and bruises in those first few weeks of full-scale telework. We had to think about how to serve our customers remotely. And it took a little bit of time to get, even around telehealth, either the technology in place or the waivers in place to allow the technologies we had to support that. So we had to, position ourselves right, but we had made big enough investments that we were able to do it, even with some grace in a few cases. And I think from a public health perspective, from where I sit, it was very simple, conceptually, to send people home and telework because we made these investments. Now, there are people who, in some cases, are heading back into an office, or they've been, asked to go back in, and that's a much harder conversation from a public health perspective. There's a lot of technology that's needed to manage the return of employees into an office and do it safely. From health screenings to understanding an employee's readiness to return into an office setting. Perhaps they've had pre-existing conditions or something. Managing PPE, managing the workspace itself, so physical distancing can be maintained. These are all public health concerns, and they're more complicated. They're more complicated to manage than it would seem, and that's where we need digital technologies to support the new protocols, the new processes, these new workflows that we have, so we can get people back into an office safely and get kids back into a school safely, so parents can go back to work. It's very much reliant on technology, and it is building on the digital transformation work we've already started. COVID has been a tremendous accelerator of these activities, I think.
Yeah, thanks, Jonathan. Maybe Andy, you can contribute, from the ONC perspective.
Yeah, I'm actually going to talk a little bit about public health and some of the opportunities and some of the missed opportunities. So first of all, when you think about the information that public health gets, public health, it really is local and state with identified information. And then as it rolls up to the federal government, it becomes de-identified for a whole bunch of reasons. Much of the data that we've been reporting on, and I also want to call out Johns Hopkins that did phenomenal work early on. It was the credible source of data on how big this pandemic was getting. But much of the data that we get is single point in time data. And what we really need is longitudinal data on an individual patient, what treatment they've received, what works, what doesn't work, then rolled up into a population experience. And that has proved very problematic. And it's problematic because for a variety of reasons, but one small example, and I emphasize it's a small example, is a lot of the testing results that came in didn't come in identified with who the patient was. And so it was a mess. Did we count this once? Did we count it twice? Did it come from here? And so I want to call out the health information exchanges. There were some really leading health information exchanges. 8 of them got together, and I realized there's some variation around the country. By the way, I'm sitting in New Hampshire now. New Hampshire doesn't have a health information exchange, but for places where they did, they have, when they've been identified as a public health authority, they have a phenomenal amount of content. And they were able to pivot and provide incredible information down to a region, city, and individual level to be able to understand things that we didn't understand previously. What were the social determinants of health in the population that was experiencing the disease? So lots of opportunity there, and it continues to be opportunity, and we continue to be very enthusiastic about that.
Thank you. Now, data is another area that's come into extreme focus. We've seen the importance of data standardization over the years, and then for various tech developments and automation of those processes around data collection, validation, and cleansing and whatnot. What are you seeing regarding standardizing data? Or what changes are you seeing in the last 12 months, I guess, to support those activities or trends that you've just been talking about? And what is the benefit of doing so? I think we can guess what the benefit is, but I'm just interested in what the actual benefits are perceived to be.
So I'm going to take the first cut at that because folks may have missed this. 2 weeks before the pandemic hit and shut down everything, we released a rule, the interoperability rule, that we had been working on since the last administration. And what folks forget is the 21st Century Cures Act, which is the statute that directed us to produce this rule, was passed with an overwhelming majority on both sides of the Hill with both parties. So there was real push, and interoperability was key in that. Patient control and access to their data, using a standardized approach, open APIs, and a requirement to share information. A lot of people talk about information blocking, and we define the 8 circumstances where it's okay to information block. We want to reframe that and talk about information sharing. The law of the land now is information sharing, and on the edges, there may be some circumstances where it's okay not to share, but the great majority of information is going to be shared. It's going to be shared at the patient's direction and preference, but you won't have clinical providers not having access, which has been the case. And then what's going to be shared? So again, I wouldn't be a good Fed if I didn't have an acronym, USCDI, the United States Core Data for Interoperability. Which is that content which is required to be shared digitally if your system can do that. And that is a very transparent public process where the content that is required to be shared is available and can be expanded as it is currently. I'll stop there and again, let one of my colleagues take over.
Well, to jump on the interoperability bandwagon, I think that's really key for the future. And to add what Andy said, and again, the ONC has been key in the past, and with their new coordinator, Nikki Tripathi, I think even more so with the interest in, since you plugged Hopkins, I'll plug the ONC. And again, I do want to take no credit for the Johns Hopkins coronavirus resource page, but if your participants aren't familiar with that, it is one of the from the ground up, it grew. But back to the interoperability, just to highlight that it's not enough to have standards. There has to be a reason to use the standards. And although for sure we need a collaboration between federal government, local government, private sector, academia, nowhere is the federal government more important, in my opinion, than bringing those standards to bear. Case in point, Medicare, Medicaid, CMS, but there's also other places. I mean, CDC and others have had public health standards for a long time. They're not always followed. Part of the problem is when you have 95, 96% of the resources in medical care, and likewise in health IT, it's likewise almost 95% resources to 5%. It's tough to talk about standards when you don't have enough resources. But I think that what we've seen in the coronavirus pandemic is that when we talk about standards, it's not good enough that a hospital can share records across the street with another hospital that maybe not be using the same vendor, but it's essential that all the public health agencies can have standards as well. And as we've learned also during the social unrest that we've had and the terrible coronavirus challenges in certain neighborhoods, social data is critical. Perhaps the other Jonathan can talk about that. There's so many federal agencies that don't always view themselves as just being medical agencies or health agencies that have an awful lot to offer. In Maryland, for example, where we do have one of the better health information exchanges known as CRISP, we link all of the state agency data across health and non-health. And again, there must be interoperability and standards for that. And the only way forward is to do that.
So I do want to add on to that, because I think very often a limiting factor in government is our ability to share data across programs. Sometimes there's a Privacy Act requirement or another restriction, but very often it's just the systems weren't built to talk together. This happens in my experience inside an agency, inside a cabinet level department, inside programs within a single agency or sub-agency. So the ability to integrate data sets and pull that data together and be able to leverage it via workflow, to be able to make it actionable, provide it to decision makers so the best decisions can be made by getting data in one place is really critical. In the last administration, we established a federal data strategy. We want to treat data as a strategic asset. Core to that is what my colleagues on this panel have been saying, this idea of interoperability, not just, from a healthcare data perspective, can, the data be read by one system or the other, but is that data accessible by those who need it when they need it? Speed and agility are really key during a crisis. And if we do not have the ability to quickly access the data sets we need via Health Exchange or some other tool, a data platform, we're not going to make the best decisions, and that could cost us lives. So I think these are excellent points that my colleagues are making.
Yeah, thank you, Jonathan. And notwithstanding the problem of the most providers are businesses, and businesses don't like sharing their what they consider proprietary or confidential information with other competitive businesses in the same area. And along that line, I guess, is with COVID and the states so actively involved, with the COVID activities, that the lack of information that can be bubbled up at a federal level to do analysis on that data. How have the analytic capabilities been hampered by the de-identification of data at the federal level, since state reporting does not include PII, etc., for the most part? So maybe, Andy, would you like to take that one first?
Sure, I'd be happy to. So first of all, it's an issue. There are some privacy issues involved, and the question is, how do you preserve patients' privacy, or for that matter, state, local governments' content's privacy, while you aggregate at a federal level to understand what's working and what doesn't work? And I can't say that the definitive answers are out on this, but over the course of the past year, we had a wonderful introduction. Folks at the NCI have developed a National Cancer Institute, just to put a fine point on that, have developed a methodology to have a privacy-sparing aggregation tool that they've done some preliminary work on, and we were very excited to hear that because, quite frankly, it opens up a world of possibility on a go-forward basis. And again, those 8 HIEs that are leaders in the field have, some of them have engaged with NCI to see how they can use their data, flesh that out, and achieve some of the goals that we're thinking about.
Yeah, one of the things I've noticed over the last 10 or 15 years I've been working here is the Department of Veterans Affairs came up with that longitudinal records where they were pulling data from, commercial providers, obviously the defense health records that were in place. They had links out to the statewide exchanges, Social Security, lots of different endpoints to pull data from to put that longitudinal record together. So maybe there's some lessons there to be learned at the federal level.
If I could jump in, there's obviously privacy is critical to us as a society, and all of us want our medical data private, but people are dying. We have about 300 times the death per population than China. We have 350 times the number of individuals with COVID, 25 million. Now, granted, privacy is not such a big deal in China, but still, somewhere in between, there's balancing act. And I don't mean to be flip. It's obviously not just about the data. But as we appreciate, so much about us is far less protected out there that we do need to balance public good. For example, in Maryland, we had a recent project where we maintained anonymity and confidentiality very strictly for data analysts for an opioid project where we linked in 10 different databases. But yet, when it was important to reach out to the patient, we balanced that with the public good to the individual good. So there are ways, and it's a bit of a red herring. And in my opinion, probably something like 400,000 Americans died in part because of inadequate surveillance, data operability, and of course, action. So there really are alternative ways, and privacy is just one of the things that we need to balance.
And I think sometimes, in the government, we've used privacy as a reason to not do something. And now when you need to start something up, you have all of the cost and all of the challenge of starting a new project up, and you're doing it during a crisis. We need flexibility in our organizations and the ability to move fast when these requirements present themselves. Also, we need flexibility around regulations and various policies so they can bend as they need to appropriately, so you can meet the needs of the day. And in some cases, I think, as Jonathan's describing, we just didn't have that. And to the extent that it's impacted our ability to respond, we need to take those as lessons learned and apply them back into the next crisis. There's going to be another. Maybe it's not a pandemic, it'll be something else. And we don't, as a federal government, state governments, local governments working together across the whole government approach now, we need to be rapidly sharing these lessons learned and internalizing them, because something bad will happen again, and we have to be more adept at our response.
Mm-hmm. No, very true. To all of the panelists, what else could be done to aid infectious disease intelligence while ensuring the privacy and ethical use of that data?
I'll just add, as we pivot to the vaccine, and we talk about the need to get a vaccination. A vaccine doesn't save somebody; a vaccination does. The challenge that we've seen is really a logistical challenge in a lot of ways. There's incredible work to create a vaccine in such a short period of time. Yet on the back end, we're using very 20th century approaches to get the vaccinations done. People can't schedule their appointments. It's challenging logistically to even know where to go, and you're asking people who are elderly or most vulnerable to log into a system to schedule an appointment. We're approaching this really in the wrong way in a lot of cases. What I think we're pivoting to is this more whole of government idea, And the federal government is, per President Biden's COVID strategy, taking a much more of a leadership role, which I think creates a lot of opportunities. But, we have to really think about what we're trying to do. And, a vaccination delivery or vaccine delivery it's a workflow. It's a process of very clear steps. And we need to be leveraging solutions that we use in other aspects of our businesses and our agencies that support these workflows, support these business processes, and applying it here. So, I think that's a very critical. We're at a very critical juncture, and using these things we know work in this case, I think, can really expedite the process and save lives.
Yeah, I want to jump in on that one. I couldn't agree more, but we also have holes along the way, and I'm not sure if others are old enough to have received their polio vaccine as part of our last urgent national immunization. I did. And they recorded that vaccine on a little piece of paper, a little index card. And I would get that index card. My parents took that index card. Yes, I'm not that old. I don't want to see that head shaking. Took that index card to her pediatrician, who put it into the paper record. Well, it's with some degree of disappointment that the technical infrastructure that Jonathan just talked about is not available, not only to schedule the vaccine and get it in your arm, but also record that you had it and have it go to the electronic health record. Right now, we plan and are in the midst of writing those down on the same 3x5 cards with the information, and have not made the link back to the clinical care, which is the place that is essential if we're going to know what works and doesn't work with these vaccines, and which one's better and how long do you get immunity for, et cetera, et cetera. So lots of opportunity there.
I fully agree with my colleagues, and just like it took us a number of months to get the surveillance at least heading in the right direction, it's going to take us a number of months. I think it's pretty much abysmal what's happening right now. I know people that have had to register on 5 different systems to get into a clunky registration, scheduling, and then get kicked off. So no excuse for that, and it is getting better. But we could have predicted this. In fact, we did predict this. But to move on to another issue, just to build a theme, and as we're running toward the end, I think whatever it takes, it's going to take collaboration between all levels of government, federal, local, and state. When it comes to public health, we at the Bloomberg School of Public Health really understand, how challenging it is just in public health to be integrated, not even to mention US and other countries. We shouldn't forget about the challenges globally. And then the bridge between medical care and public health must also be spanned. And again, that's why we started the Center for Population Health Informatics IT, because it needs collaboration. It goes without saying, don't forget the majority of our medical care system and insurance industry is private, in some cases investor owned. So we must jump across the public and private sector. And if that wasn't enough of a challenge, those of us in public health and in epidemiology appreciate that 70% of what makes people healthy isn't medical care at all. It's the social, it's the housing, and we've seen the food. So lest the audience feel like it's impossible, it's not. We've made tremendous progress just in the last year. When, God willing, COVID is over, it'll never be over. When it subsides and when we're immunized, we shouldn't forget. And we should use this to move into the future, which really does build on all these things we've talked about here.
It's not going away. Everything you read, this is not going away. We're going to be continuing this vaccination dance for years, it might seem. So we have to get it right as soon as we can get it right. But then we can't forget what we all learned. And, 1 year later, go through this process again. There's a lot of challenges to your point, Jonathan, about federal, state, and local government working together. Those information handoffs, and you have a lot of these with vaccine, how many am I getting? When am I getting them? That's where things can break down. And, we need to be thinking about the connective tissue across these systems and levels of government. So there is a free flow of information and everyone has the same information so we can make good decisions. We have to establish this now. Obviously, it's life and death at the moment. But afterwards, there are ancillary benefits for every other kind of program that we run that touches those levels of government, for better program management, better program integrity, so on and so forth. So I am very optimistic that as we figure this out, we're going to have longer term benefits that make the work of government work much better.
Thank you, Jonathan. I'm afraid we're out of time. It's been a great discussion, and obviously we need an extra 30 minutes, really. So from the Andrew, Andy, Jonathan show, thank you for joining. We're going to show a short video introducing the next panel.